Hello everyone and welcome to another deep dive session with Pekga Practical EKG Academy. Today we're going to be taking a look at this 12-lead ECG. We are going to be breaking it down and building it up, starting with a single channel and working all the way up to the final 12-lead channel. You can kind of see the difference in working in telemetry versus working in a clinical setting, or that is looking at a single channel and taking a look at a full 12-lead ECG. Now, before we get into it, just a reminder, you really should be thinking about forming your own method, whatever that is, something that helps you get through an ECG. What we do here is we have a three-step approach that we use. Rely back on this. So sometimes you're tired, you just don't know where you stopped. You can use your method to kind of get you back on the right path. The first step we do is we take a look at what stands out, and that's a good step. Sometimes you might have a mechanical issue, so something's going on with the ECG machine. You wanna fix that before you proceed any further. Or sometimes something shows up on the ECG that is so alarming that everything else pales in comparison or is not important at the moment. So you want to come back to it before you finalize your report, but at the moment you want to act on whatever's going on the ECG. And finally, symptoms and correlations. So whatever you want to ask the patient, or you want to see with the patient what was going on at the time, that could explain a lot of things that you're seeing on the ECG, or it could simply raise a red flag. Why am I seeing this when that wasn't present? So on and so forth. So these three steps will allow us to do an ECG analysis, a decent ECG analysis, and ECG analysis will allow the physician to do a diagnosis, right? So these three steps, ECG analysis, really, ECG interpretation is putting all of these steps together, which will ultimately aid in diagnosis. So let's get into it. And by the way, you can download this. I don't know if you like it, if it helps you at all. You can download it. Go to pekga.com, log into members, download it for free. Membership is free. There is no membership. So 12-lead ECG, starting with a single channel. And this is a 10-second strip, right? Single channel, lead 2. 10 seconds, I did not measure this out. This is kind of a good little trick to know. The typical format of a 12-lead ECG is exactly what you're looking at here on the screen. Each one of these segments here, all right, it's 2.5 seconds. They're 2.5 seconds long. There's 4 of them, so that's your 10 seconds, right? So this extended view down here, which can be modified, so you can modify which leads you want to be looking at in an extended version. So that's 4 times 2.5. That gives you your 10 seconds. That's why I mentioned 10 seconds. And another thing is, be mindful of the fact that here you're looking at 10 seconds, up here you're looking at 2.5 seconds. If the rhythm changes, here the rhythm goes to something different, you're not going to be able to see that interesting or changed rhythm in what has transpired before. So that's another reason why you have these extended views down here, right? Okay, just when you're taking screenshots of ECGs on your machine, be mindful of that, right? So maybe just because you captured something over here, you might want to take another ECG where that change is present in all 12 leads, right? So it always helps to have more information versus less. Okie dokie. So single channel, coming from lead 2. 10 seconds long. The only thing you can reliably do here is pull rate and rhythm. Right? When we talk about rate, typically people are talking about ventricular rate, which is good. The ventricles push the blood into the system, so your ventricular rate tends to be the most important one. However, it is a trick question. When somebody tells you, give me the rate, or what is the rate, your response should be the rate of what? When it comes to the rhythm can be a little bit tricky with a single channel. However, when you're in a telemetry setting, you do the best you can. And just off the bat, we're looking at something kind of rapid. Seems to be sinus in nature, so my first glance at this would be sinus tachycardia. Let's see if we can confirm that. Okay, so when it comes to the rate, I'm going to use the 300 rule. Oh, colors. I don't know why. Okay, colors. So I'm going to start right here, right? First box, 300, 150, 100. This is roughly about halfway between, so I would say that the rate here is 120. I would say, and what I did there is I used the 300 rule. All you do is you take number 300 divided by the amount of big boxes, by the number of big boxes. 1 box, 2 box, 2.5 boxes. So 300 divided by 2.5, 120. We can also use the 1500 rule. And the 1500 rule is just taking the number, well, I'll put it right here. You just take the number 1500 divided by the number of small boxes. So there's 5 small boxes in a big box, 5, 10, 2.5, so that's 12.5. 1500 divided by 12.5, 120. My approximation, pretty good. Pretty good. Okie dokie. So, and by the way, if you're unfamiliar with these methods, again, you can go to Pekga.com and download this ruler up here. It's a nice handy ruler until this becomes second nature to you. You can just download this, but here you have your 300 rule. So each one of these boxes will give you a rate when divided by the number 300, or when you divide number 300 by the number of big boxes. So 300 rule up here, 1500 rule, the line below it. You can download this for free, bunch of other stuff on the ruler as well. Okay, enough advertising. All right, so we got the rate. Rate is 120. That is the ventricular rate. The atrial rate seems to be in line with the ventricular rate. So the P waves seem to be merged to the QRSs, or the QRSs are merged or married to the P waves. In other words, why is my color switching back to black? If somebody out there knows this, feel free to comment. All right. Okay. So the P waves seems to be giving rise to the QRS. Taking a closer look at the P wave, they are present in front of every single QRS. So this indeed seems to be an atrial-driven rhythm. When I zoom in, see the P wave is not a nice single wave. It seems to be broken up into this M-shaped. And that is a sign that we could be looking at left atrial enlargement. See right here, it's a little bit clearer to see that M shape. This is associated with left atrial enlargement, or left atrial anomaly. In order for this to be true, your P wave needs to be 120, 110, 120 milliseconds long. Here it seems to be 1, 2, let's say 2.5 boxes max long. Is this the only P wave I'm going to take a look at? No. I'm going to take a look at a couple more probably, but 100 milliseconds. So we're knocking on the door of left atrial enlargement, but maybe we're not there quite yet. Let's take a look at another one. Let's take a look at this one. So it's from here. Right from here, here's 1 box, 2 boxes, oh, almost 3. So yeah, we indeed could be looking at potential left atrial enlargement. Now, while we're here at this P wave, let's take a look at the PR interval. PR interval, 1 box, 2 boxes, 3.5 boxes. It needs to be 5 boxes in order for this to be considered a conduction delay or first degree block, right? We don't have that. So far we've gotten the rate. The rhythm appears to be sinus tachycardia. We'll confirm that. The QRS, there's no issues with the PR segment or PR interval. The QRS itself is roughly 2 boxes wide, maybe a little bit wider. There is a little bit of a protrusion here. So this protrusion here, this kind of swooping out, that's something I'm going to have to investigate here. So something is going on there. So far, what we have here is left atrial enlargement, potentially. Heart heart rate of 120. There is no AV conduction issues. And let me talk about left atrial enlargement. So as your signal leaves the SA node, right? It's leaving the SA node, it's traveling down to the AV node. Both of the atria are getting depolarized. What happens is, on your ECGs, you get a nice little P wave. That really is a combination of your right atrium and your left atrium depolarizing at almost the same time, But when you add these two waves up on an ECG machine, the only thing you see is this big hill, right, which we call your P wave. Now, when you have left atrial enlargement, and let me switch colors. Whoops, come on, buddy, there we go. When you have left atrial enlargement, there's a couple of things that could be happening. So this is your left atrium, right? Left atrium here. The left atrial wall, so this wall up here, could be thicker. Could be. But more commonly, what happens is due to pressure. So there's a pressure buildup from maybe there's pushback from the system, right? And the wall itself stretches over time. So it becomes bigger. There's a bigger area to cover. So when this signal leaves or enters the left atrium, it takes the signal longer to cover that area. As a consequence, what you see down here, your left atrium does this. And your overall wave, your P wave, then instead of being a nice single hill, it becomes this M-shaped wave, right? But because it takes longer, see down here, this action, this depolarization took longer. We can see that on an ECG, and we can infer that we're dealing with a left atrial enlargement. Okay, now go back to the ECG. Hopefully that was clear enough. All right, moving along. So we're expanding our view. The lead 2, single channel, 10 seconds, right? This is the exact same thing we were looking at a moment ago, and all of this, we're just breaking down this big ECG. So we're not looking at different time frames. We're not looking at, different ECGs. Okay, first thing that stands out to me here is that my color is not magenta. Okay, now first thing that really stands out to me is this T wave here. See this T wave in lead V1, and let me cover that for just a second. So here we have lead 2, we have lead V1, right? This is the right side of the heart. Lead V5, left side of the heart. The T wave here is just kind of one soft swoop, and immediately my mind goes to electrolytes. So ions, in this case in particular, I want to take a look at other leads as well to confirm that we have an issue with potassium. Judging from the T wave I'm looking at down here, I would say that this is not going to be an issue, but I do have to double check it. So and we'll see when we get to the 12 lead channel. The other thing that pops out at me is the size of this S wave. This S wave is huge, and immediately my mind goes to LVH, left ventricular hypertrophy, or enlargement of your left ventricle. So the muscle has enlarged. For whatever reason, it has gotten bigger, it has gotten thicker, so there's going to be a reflection of that on the ECG and that reflection is going to be an increased wave. The other thing that comes to mind is left bundle branch block. So in V1, you're looking at typical left bundle branch morphology for V1. The QRS needs to be wide. We'll take a look at that in just a second. I want to cover LVH first. So using Sokolov criteria, okay, using Sokolov criteria, it states that we should use lead V1, the S wave in lead V1. I'm going to measure it out. So this is roughly 5, 10, 15, 17 small boxes. And then the other portion of the Sokolov criteria says that you should use R wave in either V5, which is what we have here, right? V5, or V6, whichever one is bigger. So just a quick glance here. V5, V6, V5 is bigger. So I'm going to use V5. V5, and this is 1, 2, 3, 4, 5, 6, 7, 8, roughly 8 boxes. You add the 2 up, and you get 25. Sokolov criteria states that when you add S wave in V1 and R wave in V5 or V6, whichever one is bigger, if the value that you get is greater than 35 small boxes, you do have left ventricular hypertrophy. We do not. Okay, so LVH is off the table. Now we have to focus on left bundle branch block and see if we can figure that out. Just taking a look at this ECG here, the QRS itself seems to be, this is roughly my J point right there. So the, let's see here, 1, 2, maybe a little over 2 boxes long. That's not really long enough for a bundle branch block, but let's see what else we can pull off of, what other information we can pull off of here. So far we have left atrial enlargement, we have potential left bundle branch block, or maybe something along those lines. And we do have atrial rhythm running at 120 beats per minute. So let's keep going, right? As always, the first thing that stands out is whatever stands out. In this case, it's AVL. What's going on with the AVL? So AVL is low voltage or it's isoelectric. So something is going on here. The first thing you want to do is check the mechanics. So let's see here. Is this it? Yep. There's the augmented leads, right? They're not actual physical electrodes. These are calculations. These are mathematical calculations of what's going on inside the Einthoven's triangle. So what I would do, but they are running this, they are calculating this information based off of the information that's coming off of the entire Einthoven triangle. In particular, here, you definitely want to check the lead that goes on the patient's left arm. It could be on the shoulder, it could be on the arm. Remember, you can change that, right? You can move that. Also, the other ends of these bipolar leads are placed in, one is on the left leg, the other one is on the right arm. And it also depends what kind of machine you have. You might have a fourth one down here, but I would check all of them, especially this one up here, right? So you wanna see what's going on with AVL. You don't want to leave that lingering. AVL can be an excellent indicator of something going on with the heart. And in fact, when it comes to our left atrial enlargement, it would be really helpful to see the P wave in AVL, which we cannot. Reason for that is, well, where's my guy here? Reason for that is AVL. See that? It would be running through the left left atrium, and it would give us a really, really nice view of what's going on. We don't have that option, unfortunately. So take care of your AVL. Okie dokie. Now, I want to see that this indeed is sinus tachycardia. That is, it's coming from the SA node. Looking at this, the P wave in lead 1 is upright. The P wave in lead 2 is upright. In lead 3, I cannot really see it. It's upright in AVF. And a nice bonus, this is enough to confirm that this is coming from the sinoatrial node. It's inverted in AVR. It's inverted in AVR. That's an added bonus. So this right here in a quick setting would be enough to tell you that this indeed is coming from the sinoatrial node. However, these three, much better confirmation. Okay, let's keep going. So what else do we have here? I don't know if, did we talk about QT? I'm just looking at that and I'm kind of running through my methodology in my head. And I just want to measure the QT out real quick. So from here to here, halfway point is, what is this, 2.5 boxes. So the halfway point would be somewhere here. And if you take a look at the T wave, you know, the sharpest slope, I would say it's kind of dropping down like so. And yeah, indeed, it could be running into the, maybe not quite, you know, at the baseline. I think the baseline is up a little bit. I think the baseline is in line with this PR segment. So I don't think it's quite there, but pretty darn close. Pretty darn close. So we could have a potential long QT. I don't have any demographics on this ECG, so there's no machine readout that I received with this. I just received the sheer raw ECG information. So just the waves, right? There's no absolute. I don't know if this patient is male, female, what the age is. None of the readouts are here. So I'm just running off of the waves here. So long QT possibility. Left atrial enlargement possibility. Let's take a look at the axis. So quick view at the axis, you can use lead 1 and AVF. 1 is upright, AVF is upright. If we go to our axis finder, lead 1 tells you if lead 1 is upright, that means that the signal is moving in this direction, or it's moving towards the right side of the hexaxial system, or in other words, it's moving to the left side of the heart. If lead AVF is upright, it means that the signal is moving towards the positive end of the electrode, right, which is located towards the bottom. So it's moving towards the bottom, or on the heart, it's moving towards the apex. In fact, lead AVF really would be moving this way. I don't know why I drew it that way. And this lead 1, oh my goodness. Sorry, let me just fix that. Lead 1 really should be running across like that. And now when you add the two vectors together, what you get is something in between. And here you get something that's in alignment, really almost perfect alignment with lead 2. Okay, let me get rid of this real quick. All right, going back to it. So lead 1, lead AVF, just a quick method. If you want to complicate this method a little bit more, you can take a look at these 3 leads, right? 1, 2, 3, and 1, 2, and 3. So in lead 1, it's upright. In lead 2, the QRS is upright. In lead 3, the QRS is upright. You go back to the axis finder. Again, you can download this at Pekga. But here's lead 1, lead 2, lead 3. They are all upright. We are in this quadrant. Okay, so a couple of confirmations of the major axis of depolarization, and it's telling me that it's probably right at 60 degrees, which is good, which is perfect. It's textbook perfect, really. Okay, what else can we pull off of here? Looking at these waves, we have that slurring present. See that kind of like a little kick at the end. Where the QRS, here you can see it really nicely. See that little protrusion? So this seems to be happening globally. It's present in AVF as well. Okay, now I'm going to switch gears and we're going to switch planes. So we're going to go from frontal plane, we're going to go into horizontal plane or transverse plane. So we're going to be going from the Eindhoven triangle into the precordial leads, where we're going to be taking a look at the R wave progression, right? R wave progression. You're looking at where the QRS switches from predominantly negative to predominantly positive. It should be happening somewhere in between lead V3 and V4, right? I'm sorry, this is not apparent, but lead V1, V2, V3, V4, 5, 6, right? Let's see if that is indeed happening. So here, R wave, small, bigger. Here it's fragmented, but it's bigger still. The QRS is still negative, and then boom, it goes positive. So that change in R wave progression, or the QRS becoming positive, happens in between V3 and V4. That's good. However, Now this is interesting. We have a fragmented QRS. For those of you seeing this for the first time, oftentimes you'll see this label F, small f, and then capital QRS. It stands for fragmented QRS. If indeed I had fragmented QRS, something strange, something very strange. So not your typical right bundle branch block, left bundle branch blocks, but something more odd. Like for example, I had something like this. Just an odd, bizarre looking QRS that seems to be kind of cut up. That is a fragmented QRS. Here, this is enough to call it a fragmented QRS. But if you had something along these lines, or even this, and it was present in contiguous leads, contiguous meaning continuous, so it would be present in like V2 and then also in V3 or in V3 and in V4, that's a red flag. You need to investigate that. Here it's just in one. So I'm not sure what's going on here, not yet, but it's present in only one, so it's not a red flag. Okay, let me just see here. Okay, we ruled out LVH, right? But left bundle branch block. Now this fragmented QRS is kind of giving me an idea. I'm going to zoom in here, and I'm going to measure this out. So the QRS here, I'm starting with the first in deflection, positive deflection, and it is correlating to the QRS in the previous lead, which is wonderful. The J point, I can find it right here. I'm going to pull another line up here, and then I'm going to measure my QRS. So the QRS appears to be 1 boxes, 2 boxes, roughly 2.5 small boxes long or wide. 2.5 small boxes is roughly 100 milliseconds. That's a little bit less than you would expect to see with a bundle branch block, but that's a complete bundle branch block. And let's talk about that for just a moment here. Let me see if I have this illustration. Oh, yeah, here it is. Whoops. Oh boy. Here we go. So in a typical left bundle branch block, so left bundle branch block here colored in blue, right bundle branch block, we're not going to be talking about this, don't let it confuse you, but it's in magenta. So what you would expect to see is, this is what typically people associate with left bundle branch block, right? You have this big giant negative QRS in V1, and immediately people will label it left bundle branch block. Most of the time that's true, but your QRS needs to be wide. It needs to be 120 milliseconds, according to most literature you run into out there. It doesn't necessarily have to be 120 milliseconds. However, you do need to have some sort of a widening in lead V1. So this is a lateral lead, right? It's looking at lateral segments of the heart. You should be seeing a widening in the QRS in lead 1. Also, you should be seeing a widening in V6. So your lead 1 runs this way, your V6 is almost in complete alignment with this. So you should be seeing this alignment, right, in both of these leads, along with this morphology in lead V1. Okay, now let's go back to the ECG if I can here. We don't have that exact same configuration, but we do have this slurring, right? See how this R wave kind of kicks out? And that's really bothering me at the moment. But let me see if I have this. I do have it here. Hold on just a moment. So when it comes to the left bundle branch block, what happens is the signal is coming down from the, there we go. The signal is coming down from the AV node, right? It's bifurcating into the left and right bundles. And in a complete bundle branch block, this will get blocked and the signal will continue in the right bundle. And what happens is the signal quickly enters all of the right bundle. And because the signal got blocked here in the highway system, in the His bundle system, right, His Purkinje system, what happens is the signal travels from the right ventricle, cell to cell, into the left ventricle. And this is a giant piece of heart tissue. It's a big amount of mass. So what happens on the ECG, you will oftentimes, oftentimes is, I misspoke there. You will always see this very quick, rapid inflection or depolarization that is representative of your initial right ventricular depolarization, and then as the signal enters the cell-to-cell depolarization, you will see a slowing down. So it's taking longer for the QRS to complete this depolarization. Therefore, your ECG is going to take a longer time for this wave to happen, right? The wave gets fat, it gets wide on your ECG. Okay, I think that was probably clear as mud. However, we don't have a complete, let me see if I can find this. We don't have a complete blockage of the, I would not say so, of the left bundle. But what if the left bundle was blocked right here? Now, if the left bundle was blocked partially there, you would expect to see some aspects of the left bundle, like maybe that, right? And you would expect to see slurring, and this is global, which is kind of interesting. And this V3 is also interesting to me. So when I add all of these pieces together in my mind, what I have forming is that this block is happening somewhere a little bit more distally. So it's not happening right here, right? It's not happening right there or right there. So somewhere immediately after the bifurcation, it's happening later on. And right here is where my suspicion lies, is the issue that we're looking at is coming from. Why do I say that? Your R wave is your major ventricular depolarization. So these are your ventricles. Your R wave is representative of major ventricular depolarization. Your S wave, if you have it, right? This is your isoelectric baseline. Your S wave is representative. Your S wave comes from this basal region. Basal region, right? You have base of the heart. You have apex of the heart. If you divide the heart into ventricles and atria, you can refer to this region as a region that's closer to the base of the heart. That's why it's called the basal region, right? Your S wave would come from, your S wave represents depolarization in that region. However, if you don't have an S wave, what you might expect to see is a kind of widening of the R wave at the very end. And we do see that, right? We do see that globally here. So yes, indeed, I would say that we do have an incomplete left bundle branch block. When we add all of this stuff up together, what do we have here? Oh, by the way, let's not pack up our bags yet. I want to discuss left atrial anomaly or left atrial enlargement a little bit further. So, we talked about these basal regions here. Let me just get rid of this. So we talked about left atrial enlargement. Left atrial enlargement, right? And then there's an issue with the left bundle down here, some sort of an incomplete block. There's a structure in between those two phenomena, if you will, and that's your mitral valve. So your mitral valve is the valve that connects the left atrium to the left ventricle. There could be an issue with this mitral valve. Okay, so everything we're seeing on the ECG could be indicative of some sort of an issue with the mitral valve. And why do I mention that? When we go back to the ECG, if you were just to hand this ECG over and say to somebody, we have sinus tachycardia at 120 beats per minute, and that person, let's say that for whatever reason they were not interested in investigating any further, that's it, end of story, right? However, if you hand this piece of paper to somebody and you say, we have sinus tachycardia at 120 beats per minute, we have an incomplete left bundle branch block, we have a borderline left atrial enlargement, and I forgot to add to here, borderline long QT, and we need to investigate what's going on in AVL. And by the way, AVL would have been a great lead to figure out what's going on with the left atrium. Let me see if I can go back to that real quick. So see here, lead AVL is looking at what's going on right here. Well, more like right there. But we don't have that segment. We don't have that segment. It would have been beautiful to see what AVL tells us about the P wave, or the progression of the depolarization to the left atrium, but we don't have that. If you were to fix that, you could probably confirm 100% that indeed you do have left atrial enlargement. However, we don't have that. So when you hand this over off to somebody, or you enter the report into your system, if you leave it at sinus tachycardia 120 beats per minute, that is very much incomplete, right? However, if you add sinus tachycardia, sinus tachycardia 120 beats per minute, incomplete left bundle branch block, left atrial enlargement borderline, you have an issue with AVL that needs to be investigated. All of a sudden, this report becomes a lot more interesting. Thank you for joining me on this deep dive. Hopefully you learned something. Again, there will be a there will be a link in the description down below for a rapid or quick version of this video, where we just kind of go into reading this ECG without so much explanation of what it is that we do and how we do it. And again, thank you. We'll see you on the next one.